So I'm going to start the questions with our new panelists, and maybe start with Dr. Chen and Dr. Brook. Um, what are the essential elements of pre-medical and preclinical education, and which ones are at risk of becoming neglected in modern education, and how can they be preserved or integrated with new technology? So feel free to say anything, and then we'll have Dr. Weinberg and Dr. Emanuel add what their comments are. Okay. Go ahead, Dr. Chen.
Thank you, Jason, and hi, professors and all our friends. It's my great honor to be here. So I'm Huilin Chen. I'm a pediatrician, and I'm also a director of Graduate Institute of Medical Education and Bioethics from Nation Taiwan University. So for some friends from foreign countries, I will briefly introduce the medical school in Taiwan. And most of the medical students in Taiwan program as an undergraduate program. We involve 6 years of undergraduate years after high school, and 2 years postgraduate years for general medicine training. So in the 6 years, the first 2 years are pre-medical. So we involve many general courses, including liberal arts and humanities, not only medical, so like philosophy, psychology. And we also introduce medical humanities, like in NTU. Since the 2nd year, we have a small group tutorials discussing different kind of issues. And so the 3rd, 4th years preclinical, and the 5th, 6th years clinical. So in our courses, we incorporate more and more medical medicine and technologies the years up, and the more general liberal arts and humanities in the first 2 or 3, 4 years. But nowadays, we reinforce that we need to incorporate medical humanities into all the 6 years, so all through the years, and even the postgraduate. So I think in Taiwan, we usually think that we need holistic care for the patients. But we also feel that we need to cultivate our students from the beginning, that they are a human, and they need to know how the career path, the professional identity from the beginning of medical years and through the 6 years. So nowadays we got a big challenge because more and more new technologies and the knowledge tsunami that increase every year, that we need to teach them this, teach them that. And especially we talk about AI, like in the early 2023, when the generative AI was there, NTU have announced the open attitude toward the learning and teaching in our university. And we all also incorporate this attitude into our medical courses. So now in NTU, we have AI courses like in the required courses in the 3rd year, 5th years, and also along with the high technologies, newly advanced personal medicine and everything. I think that's a lot. And interestingly, we have a survey, we have to research the courses, especially during COVID, we have used online courses, tutorials, and we felt that the role of teacher as a lecture teacher have decreased, and so that we think that students, they have more and more self-directed learning abilities, and we want them to do so. So we were thinking that how the role is the teacher is. So we think that in this era, the learning and teaching should be go hand on hand. And we also have more and more faculty development courses and efforts to cultivate our teachers how to teach this AI, how to teach them these new technologies. And also they are teaching through learning. So it's more that teachers and students are co-learning, and it's not that we need to learn more. It's that we need to learn the way of learning, and we need to change the way we learning. And teachers and students need to advance together, hand by hand. And also along all these medical sciences, new technologies, we should always keep the medical humanities inside. So we have used case-based discussions like in our third years, and we let the student do how they can have generative AI aiding their medical decision. But still, we also in the case-based discussion also make the biopsychosocial elements into that discussion. So it's all blended together, and we want this habit to go into the clinical years, and that's our hope and how we do it briefly.
Dr. Brooke, do you want to share with us your experience at UCLA?
Thank you. And I just want to echo how privileged I feel to be here with you all today. So I think, UCLA changed its whole undergraduate curriculum about 2021 was the implementation date. It was a little bit delayed because of COVID, where they actually made it so that they compacted the preclinical training, they kept the clinical clerkship time the same, but they gave students more time for research and discovery, which allowed them to pursue dual degrees. And we are now going back to the fact that we actually should be seeing the same number of patients. There's a reason medical school is 4 years, and to get 2 degrees in 4 years never quite made sense if you're thinking about becoming a competent physician. So I think that what was an interesting phenomenon was the piggybacking of AI with COVID. Because due to COVID, and I know Taiwan didn't have this experience, but in the US, students didn't learn physical examination in the first year of med school. They were not able to learn it. You didn't look into someone's mouth. I had students who were sub-Is in their advanced electives and had never done just like an ENT examination because they got trained in COVID. And so with the electronic medical records and then the COVID and now AI, there's this, I don't know if it's a belief or just certainly a habit now amongst residents and learners where you don't need to see the patient to get the information to treat the patient. And I think that's a very dangerous phenomenon that we're seeing. Like you'll have residents who will decide antibiotics based on cellulitis, and I'll say, what did the leg look like today? And I don't care how smart you are, how many antibiotics you know about. If you've not seen the patient's leg every day, how are you supposed to decide when to de-escalate those antibiotics? So we are actually in a really big, I would say, push to go back to the bedside and make sure we're doing that regularly. Because again, in COVID, those practices that we did so consistently got lost because they were no longer allowed. And as an attending, I will constantly say to them, well, so what did how did the patient feel after the pain med? Or I saw that they'll say if they got the pain med per the electronic medical record, did it alleviate their pain? Because the medical record cannot tell you if it alleviated their pain, but it can tell you if they gave you the pain med. And so there's so much information now that they can get. And there's also so much more paperwork that they have to do just to get a patient discharged or all that there is a lot more administrative tasks. But we need to make sure that we're seeing our patients every day and that those physical examination skills, and I'm not talking just about POCUS and ultrasound, because I think ultrasound's great actually as an adjunct, right? But this idea that the stethoscope is no longer going to be necessary is something that I think is very sad. And I think that is, this idea in medical school trainees that it's more imperative to learn how to use an ultrasound than a stethoscope. And so I think that our medical school is going back to increasing clinical exposure in the first year, to increase those physical examination skills, to learn that the expert of that disease is going to be the patient, because it's going to be how that disease presents as an illness in that patient. And you have to know how to take care of that patient in the context of their disease and their life, which is going to be different from every other patient you get. I think in terms of AI, what I worry about the most is exactly what Dr. Manuel was saying, that we're not going to be anywhere near where AI is good enough to rely on it. And if we don't have learners who can't critically think, then they can't validate what the AI differential gives them. It's sort of like when you work with the first year learner and you hear them ask the consultant the question and you're kind of cringe, you're like, oh my God, that's not really how I wanted you to ask the question, that wasn't quite the point. But then by the time they become senior learners, they know exactly how to ask the question because they've developed clinical reasoning and they know how to do the right prompt, the right question. And we need to be teaching them how to ask the right questions. We need to be teaching them how to critically think. Because at this point, it's AI plus the physician still. And I think the concern is that they will be much better at it than we are. There's no question, because they're going to play with it more and experiment with it more. And so I think we do need to have, we do want to control the narrative of how AI is used and make sure they're using it ethically, appropriately, and in safe ways for our patients. But I think that critical thinking, medicine is something where you get evaluated by being right. It's still that academic competition to some degree. How do we grade? We evaluate, like, does someone know the answer to something? And I think we really need to start moving away from that. And it's not, do they know the right answer? Because the right answer is now very look-upable. I don't care if they've memorized Duke's criteria. I want them to know they need to know Duke's criteria and where to look it up. I care much more about how do they apply Duke's criteria and do they apply it correctly. And that's gonna take a lot more time to evaluate and a lot more investment in helping faculty evaluate that. But I think if we really wanna make sure our learners are critically thinking, that's where we have to go.
I would like to echo Rachel 100% that after COVID, the physical examination have been not a habit for many doctors and also the bedside teachers. So we have medical students in second year to have clinical shadowing. They usually think this is very helpful for them to see what the path they are going to have. And we are very grateful that Professor Lai Qi-Wan also emphasized bedside teacher through the years of clinical medical students. So I think so how we can emphasize bedside teaching and physical examination at this time, because not many colleagues agree with us 100%. They said, yeah, in the future everybody would have an echo with handphone. Should we have the ability for the physical examination? But one day, just recently, one senior friend complained to me. I went to the clinic, the doctor never touched me, and then I go out. And how can he know how my disease, or how can he make decision without touching me? So I think, especially the end of care life, can a robot giving the communications, even they are very right. So I think how can we retain the bedside physical examination and as well as embrace the new technology? I think that's a challenge for us.
Well, I think the two comments bring up two things I think are important. One is about the amount of time we need. I think certainly in the United States, I would say maybe even in Taiwan, medical school's too long. We still largely rely on the length of medical school from the early part of the 20th century. In the United States, we still have 2 years preclinical, 2 years clinical, based upon, the Flexner report in 1910. Most medical schools have shortened the preclinical time because a lot of that stuff, as Rachel pointed out, is look upable. It's not actually critical. I have two sarcastic comments about that from my own training. One is, I learned the Krebs cycle 6 times in medical school. I can't tell you what it is today, and I never used it in clinical practice once. I'm not sure why we're still teaching it. The second is, I don't know what I was taught what a lentivirus is. I don't know what it is, and I don't know that it makes a difference for any therapeutic. Why are we doing much of what we do in the preclinical time? My own suggestion is it's just inertia, and faculty, they resent teaching, but they don't want to take it out of the curriculum. I mean, it's a very contradictory attitude. We could cut back to 1 year, 15 months, something like that, and still have the 2 years of clinical time that is so important. And so I think if you ask what's essential, anatomy's essential. There's a lot of pathophysiology and learning how to understand pathophysiology that's essential. There's other things that need to be in the preclinical, but most of the most important things are in the clinical. And so I just want to make one other comment about the clinical time that I think we haven't raised here. Traditionally, again, since 1910, at least in the United States and most other countries, clinical time is hospital time. Hospital time is not clinical time anymore. It gives us a very distorted view of what patients suffer and how to care for patients. I'm an oncologist. Certainly, the vast majority, unless I was doing bone marrow transplant or CAR T, most of my clinical time was outpatient. Had nothing to do with the hospital. We need to figure out, and this is very complicated, how to train students more in ambulatory care than clinical rotations. And I think that is still something we're not great at. It's hard to do and organize just because you have, 140 medical students every year, or whatever the number is, and having them work in the ambulatory side is just administratively and logistically very, very complicated. I think much more of that time, much more is going to have to be on the ambulatory side. Especially, I don't know, again, forgive me, but I don't know the situation in Taiwan, but in the US, we talk about hospital at home, moving patients out of the hospital and treating them at home, which is very different than treating them in the hospital. And so we need to be training those kinds of skills much more. Let me just say, and again, I don't know the Taiwan situation. In the United States, the peak, the year that we had the most patients in a hospital, both absolutely and relatively, was 1981. Since that time, the number of people in a hospital has gone down, down, down. We're less than 1 million people now per 330 million population in the hospital in any one year. Medicine is just not hospital-based, even though our training is still very, very substantially hospital-based. So those are the two things I think we should do. Shorten it and less hospital.
I think just about the hospital versus ambulatory point, because I think this is something that also affects with the Taiwan medical education as well, is how much harder it is to teach in the ambulatory setting, right? And that's why so much of our teaching takes place in the hospital. And you're absolutely right. It doesn't help prepare you. One of the questions on here is, how do we help prepare learners for patient overload and technological advances when they become faculty? And it's one of my most stressful things when I train my residents and learners, is that we don't, because a large of what they're going to do is going to be in a clinic. And I think that you have to think of two things you're training, is just what I would say. If you're training basic clinical reasoning and ability to just do critical thinking, I think you can do it in either, right? And I think that if one is easier, if the hospital is easier because it allows for that time, then that might be the way to use the hospital setting to teach that skill set. But I agree with you, if you're thinking about preparing them for their job and how they're going to actually practice, it's not as effective. But at least, for us, to make clinic time means patients have less access to doctors. And we talked about how there might be longer time with doctors in the US, but 10 days is a remarkable wait time. I was thinking like 4 months of a wait time. So I think that is the tension that I feel with my department leadership when I ask for our faculty to get more block time in clinic in order to be effective teachers, is in their response to me is, Rachel, who's going to see the patients then? And so I think that is it's a point that needs to be resolved. I agree.
I wanted to make sure we get to the other questions, but we could always come back to it if we have more time. So we talk about meeting patients where they are. We talked about modeling humanistic care and empathy. How do you teach that? Can it be taught, or has it to be modeled, or how do you do that?
In our courses, we have multiple courses to enhance the communication skills and the empathy. For example, we rely on the standardized patients. We have courses of case discussions. This is mostly during the clinical years. So we have in each department rotations, the communication and the discussions. So I think we bring them these integrated because although we thought it's a preclinical and clinical, actually our courses have blended to be integrated and like a system-based. So in each case-based discussion, we incorporate the science, the communications, the ethics, and the public legal problems, and the difficult communications issues. And we even invite different discipline students to come together. So that's what we do now in our medical school. And we also have other opportunities for the students to participate in the clinical scenarios, clinical works. So I think we try to put it blended into all these courses. Even if you are teaching anatomy, we emphasize the humanity. Like in Taiwan, we usually call the silent mentors, and we have the student to visit the family of the silent mentors. So in that courses, they have incorporated the humanities into our course. Yeah.
I agree completely. There are checklists now and ways to teach nonverbal cues and behaviors to help at least increase empathetic behavior and make sure that the intent of the learner or the student, if they're trying to be empathetic, is perceived. And that is taught throughout the preclinical years when they're doing their patient communication skills with standardized patients. They actually get feedback from the standardized patients on that checklist as how it felt for them to be on the patient side. I think for the humanistic care, Dr. Feinberg mentioned his role model during clerkships, and I think it's so important to label what we do. And oftentimes we don't know what we do that was humanistic, and so it is something to say, when I want to make sure that if I know I'm having an important conversation with the patient, I will put my phone in my pocket. Something very simple. Or I am going to take a moment before I go into this patient's room because that was a hard encounter with the last patient. I don't want to carry that encounter with me to this patient. But labeling what we do to our learners, I think, is really important, and encouraging us to even be able to name those behaviors. But I think that the role modeling is wonderful. The labeling will make it so that someone who is not as observant may also get that training and be able to care to the next patient.
Dr. Pai.
Thank you. This is such an interesting, important conversation. On the point of communication, sometimes I think we think of it as learning to explain things to the patient. And communication, there's a reason we have 2 ears and 1 mouth. We should listen twice as much as we speak. And hearing the patient, actively listening. This is a skill that I think we don't concentrate on as much as we should. Some schools have adopted a training model where they record the interview of the patient and the clinician being, in this case, a medical student. And they will then, the instructor will review the 4 student interviews. And the next session with the students begins with the instructor showing excerpts from the interviews where the patient obviously misunderstood and the student didn't pick up, or the patient was saying something or positioning in a way that the student didn't respond to. And this kind of experiential learning with feedback, I think is a very powerful mode of absorbing key lessons, because it's based on your own experience and direct interaction with the patient. Finally, I would just say, to take a step beyond from hospital to ambulatory care, some schools have a model where a medical student is assigned a patient and family who have had recent discharge. And they meet with the family, of course the family has to be willing, they meet with the family in their home. And they meet weekly for 2 months, and their job is to help that family navigate their medical needs. But the point educationally is to understand that illness is just one part of life, and what the family is experiencing in connection with their health care is just a part of what they're coping with. And that's a very eye-opening experience about the role of the interested and committed clinician in people's lives. So those are a couple of things I think that might speak specifically to this point of communication and empathy.
Thank you for all the panelists. We're gonna shift a little bit to health systems. And this time, I'm gonna ask Dr. Emanuel and Dr. Feinberg to comment first, and then Dr. Brook and Dr. Chen to add to it. So, how do we build a health system that promotes ethical practice, innovation, and excellence? What reforms are needed to align health systems with public health priorities while maintaining individual patient focus?
Lifetime doing this.
I think that's a very big challenge. And, you know, one of the biggest challenges, certainly, again, I think in the United States, just has to do with the finances. You know, hospitals, I was just literally yesterday looking, 40% of our hospitals are running a deficit. It's very hard if you're making choices where some of the choices may decrease your bed flow and therefore decrease your revenue, to make an ethical choice if the alternative is, no, we'll get more patients and it's only a little unethical. And I think this is a very common problem. The second problem, I think, is hospitals are not entrusted with doing 2 things that are really critical for public health and other issues. One is they're typically not required or entrusted, or, I mean, they're required to report, but they're not public health focused. They tend to be focused on acute illnesses. And as we all know, again, Harvey's put up just to remind us, you know, the 21st century health problems are not acute illnesses, right? We go into a hospital for 5 days, 7 days for acute care, not for chronic care. But most of our health problems of our populations are chronic care. And hospitals are very poorly outfitted for chronic care and for public health measures. They're, patient-focused, acute interventions get the patient better even if they have an underlying chronic disease and discharge them. And the continuity of care is not their primary focus. And I think if we're really going to think about hospitals for the next 50 years, we have to think about either broadening them out or diminishing their role and emphasizing much more those parts of the healthcare system that deal with chronic illness, that deal with continuity of care, and that deal with public health. Those are the things we know make a much bigger difference in people's health and wellness and longevity. And so if you ask me, I think one of the key things is we shouldn't keep stressing hospitals. Every healthcare system that I've looked at, its hospitals are the biggest source of, or take the biggest amount of the healthcare dollar. In the United States, it's a third of all healthcare dollars go to hospitals. It's simply too much. We should reallocate more to public health and more to those parts of the system that deal better with chronic illness at patients' homes. I think that's where the future is. United States, despite the fact that 1981 was our peak year of hospitalization, let me assure you, hospitals still take a third of all the money like they did in 1981. Nothing's changed. It's just more intensive. We haven't reallocated to where the real focus of care has to be. I don't know that I've answered your question because I don't think there's a simple answer to it. It's much more of a systems problem.
Yes, Jason, they say to every complex question, there is a straightforward, simple, obvious answer that is wrong. So we have to recognize the reality of the difficulty. If you ask me to wave a magic wand and to say, okay, you're now in charge of designing the health model for the United States or Taiwan or any country, I would begin by saying we have to be careful when health is a public good not to treat it as a private commodity, number one. Number two, we have to do what Zeke was saying, which is to organize our health program, system of care, and preventive services on a population basis. So what I would want to do is design a public corporation or two, because I love competition, which would have a preponderance of community civic leaders on the board of control. And that would be the obligatory controller of the hospital resources, clinician engagements, and public health authority for a defined geography. And then you would have a chance of taking the resources that we know are being used either wastefully or inefficiently, and redeploying them in a way that looks to genuine health of people, not just their acute illness, looks to the long term and not the incident, and looks to the total population and not just to the number who are able to gain access. So if you had that kind of responsibility, and instead of UCSF and Stanford merging, they would each get in the business of the Bay Area responsibility. Pittsburgh has a natural setup, actually, because it has two major systems. They could take up the county. In Los Angeles, LA County is an amazing place. There's an opportunity in LA County. There's a place that this could work as a pilot in many states of the US, and I think in other places. But it's a clean slate. You have to be ready to take down a lot of the existing structure. But in the long term, I don't see us incrementally reaching the ideal that you described.
Thank you. Just currently Taiwan is having such a debate on how to move the health system more towards focusing on health. And as you know, the Taiwanese president is a nephrologist who went to Harvard School of Public Health. So I think we're gonna send him this clip on your suggestions and your suggestions. Having two public systems competing with each other with key stakeholders on the board and to see what he thinks.
Well, I think Harvey said one other thing that's really important, really important, which is not just two health systems. They also have to be responsible for a defined population. Because one of the problems of any health system, certainly in the United States, but even is people come in and out of a healthcare system, or if you had two big health systems, they would switch healthcare systems if they weren't in some way defined population, and that in and out is very costly because it means there's no good reason for me to invest in someone if they're going to leave my healthcare system. Now, of course, some people are going to move, some people are going to change jobs and things like that. But I do think this idea of a defined population, places that have done that have done much better, because then the healthcare system itself has an incentive to invest. We do it terribly in the United States. Even Britain, they have one national healthcare system, and everyone's basically in it, doesn't do a terrifically good job of investing for the long term.
I'm gonna shift a little bit to sort of patient feedback, the patient feedback system that may reflect and incentivize humanistic behavior or not. Are there better ways to assess care other than sort of what we typically do with technical quality and patient experience? And what are the next steps maybe in measuring quality of a health system? Start from, maybe Dr. Brook, you will start because patient experience, you must be getting those feedback on a
Yeah.
regular basis.
UCLA just put up all of our stars, so now when you look me up, you can immediately see if I have a 5-star rating or not. And it was a big, rollout by the health system to explain why it was going to be beneficial for all of us. I think that in terms of, I'm a half primary care physician, so I actually do half hospitalist, half primary care. And I will say that I have never finished a clinic on time, ever. I start on time. And because I do a lot of different things, I'm not someone who my patient messages are not responded to in like 30 minutes. Like some physicians are just like always at their computer. And my ratings are high because I have time. And I set my career up in a way where I have time, and I think patients want to feel valued and they want to be heard, and time is a big way to do that, and we don't get time, unfortunately. And so I do think that it is, I actually look at my patient reviews and they're very honest. They'll be like, how timely is your physician? And that will be my lowest score in terms of on time for the appointment, but I'm a 5 in terms of would you recommend this physician and do you value them, because they feel very satisfied with the care. And I think that, so it is important to look at that, but I do think that there are so many incentives to get good patient reviews, because you can get different reimbursement, is my understanding, and I'm not an expert in this. And so I think that you want to make sure your patients feel good with their care because you care about giving patients good care. But unfortunately, I think the way that patient reviews are incentivized, I don't know if they actually lead to more humanistic care or they lead to interventions in order to get better patient reviews. And I guess that, yeah.
Does Taiwan collect patient experience data?
Yes, of course, we collect patients' feedback every day, and mostly are to the physicians or the medical teams. So they have thankful feedbacks. I think that very encouraged for for the medical team and some of the complaints. And so I think that's mostly feedback to the hospital running and the medical care. And many are on the communications. They thank for the good communication, even the medical situation is very tough. And they complain inefficient. And I think the most important are on the administrative parts, like a registration, waiting time. And I think the hospital have done a lot through these feedbacks. But I think we can do more to incorporate these as the teaching materials for our students. We haven't done so, I think.
Publish it on the website, like UCLA. It's not published on the website, right?
No.
Okay. Any, I was told we are heading to lunch, but Dr. Feinberg,
Well, I know our time is up. If I were trying to convey one key message to medical students, it would be put the patient first. Put the patient first, and everything else will follow.
with that, I think, thank you for actually solving a very complex problem with a simple solution. Put the patient first. Thank you, everybody. I want to thank all the panelists, and it's time to go to lunch, and we'll come back in an hour.